and recovered from that those football games were exciting. They were nail biters, y'all. Down to the wire. Hope your heart rate slowed down. Mine finally did. Be sure and post any questions that you have in the chat. Amy will share information with us. And then, Amy, do you want to answer some questions as you go along, or do you prefer to hold them till the end?
Sure. I mean, I can pause, as we go along if there are specific questions on certain topics, and we'll be very flexible with our approach.
I thought you might be. We've got just another couple of minutes and then we'll get started. Got a great group. Oh, lots of good questions already popping into the chat. Fantastic. We'll wait one more minute. It's not quite 11 yet. I should say noon if you're on the East Coast.
9 a.m. out here in California.
Bright and early on the West Coast. So Amy, you'll share your screen for your presentation here shortly.
Yes.
Fantastic. All right, it's 11 o'clock. Let's get started. I'd like to welcome each of you to the LUNGevity Foundation special edition meetup, y'all. Today, it's all things COVID. This session will be audio recorded. And as always, information obtained in this or any of our virtual meetups should never be taken as medical advice or guidance, which we would encourage you to discuss with your provider. We are so excited today. We have our very own Dr. Amy Moore with us. Amy is the Vice President of Global Engagement and Patient Partnerships at LUNGevity. And boy, she has her finger on the pulse of COVID. We are grateful for Amy. Amy, we're happy you're with us today.
Thanks for having me. So it's great to see everybody. Happy Monday. And I know everybody's, just trying to get through this insanity of COVID, and Omicron was the thing that we didn't need coming into the holidays of 2021. It kind of rained on our Thanksgiving and Christmas parades. And I know I was scheduled to go visit family back home in Georgia and South Carolina, and we scratched those plans because we just didn't feel it was safe for us to travel and then potentially bring an unwelcome visitor with us to see our parents who are aging. So I know everybody's dealing with the impacts of this and frustrated and confused. So I put together some slides that I think will address a lot of topics that are top of mind for many people. I see there are questions pouring in, so I'm going to rely on Christy and Katie to keep up with that and make sure that we cover them. So I will share my screen and get started. So just bear with me one moment. All right, so let me get to my PowerPoint here. And let's see. Can everybody see the slides?
Yes.
Okay, great. So, I called this Omicron, how to find your OM in the ONG. How can we get to a place where we can feel some level of peace or comfort in the midst of this ongoing insanity of the COVID-19 pandemic. So hopefully I can share some tidbits with you today that will answer some of your lingering questions and give you the opportunity to feel at least educated and empowered as you make your own personal decisions about how to keep navigating what seems like an endless situation. So specifically today, I'll be covering what we know currently about masks, some information on testing, PCR versus rapid test, the updated CDC guidelines, national trends. I think of kids in the car on vacation. Are we there yet? Is this, trip over? The risk to patients with lung cancer, what we know about boosters, and kind of an assessment of what the future may hold. So that's our agenda today. And as I said, as I go through these topics, if you have questions, feel free to raise your hand. Again, Katie and Chrissy will be monitoring the chat as well. And hopefully we'll have a good discussion. So masking, this is one of the most important kind of non-pharmaceutical interventions we have to keep the pandemic at bay. The science is clear now that masks work, and they're critically important as an additional piece in addition to vaccination and boosting that can help us. So what we know is that cloth is so 2020. When this pandemic first started, we had supply chain issues, and surgical masks and N95 masks were hard to come by, and the guidance was to really preserve those for our healthcare workers. We're now 2 years into that, and that's not the reality anymore. We have masks that are available, and what we know is that this game has changed. Omicron is extremely contagious. We thought things were bad last summer with Delta. Omicron has changed the playing field. So it's extremely contagious, very easy to catch. So it's time for all of us to up our mask game. And in fact, the CDC has come out with recommendations that we all transition away from cloth, if possible, to at least surgical, preferably KN95 or N95 mask. And so I've got a figure here on the right where I just want to kind of reinforce how well masks work. So across the top, you have the example of a person who is not infected, who is either wearing nothing versus a cloth mask, a surgical mask, or an N95. And across the left side, you see the person infected is wearing either no mask, cloth mask, surgical, or N95. And what you see is a gradient of protection. I don't want you to fixate so much on the absolute times and think that those are a guaranteed time. But what we know is if you go from neither person wearing anything, you have about 15 minutes before you're likely exposed and going to get infected. And that's kind of that 15-minute rule that we've all become accustomed to in this pandemic. When we define close exposure, it's really those 15-minute increments. The reality with Omicron is it's probably even less. So it's so contagious that you're probably going to get exposed before 15 minutes have elapsed. But as you go down to the lower right corner, you now see that if both people are wearing an N95 mask, you've got about 25 hours of protection. So clearly, upping your mask game is going to make a difference and provide you the most protection possible. Now, I know also that people have been a little bit confused because maybe they go on Amazon and the number of choices is overwhelming. There are lots of options to choose from. How do you know if you're getting something that is a legitimate mask that's actually going to protect you versus maybe a counterfeit mask? Hopefully some of you have heard of this project called Project N95. The good news is you don't have to figure that out. There are people who've already done the homework for you. And so if you go to this website, they have a list of available masks of different types for adults, for children, KN95s, surgicals, N95s. They've already vetted them. They're ready to ship. You can go there and order your mask. So please, please, please up your mask game. It's critically important. It's going to protect you. I'll pause there. Does anybody have a question about masks? Okay. So the next big issue that we've all been grappling with, oh, sorry, there is a question. Lynn, you're on mute.
I'm sorry. So
That's
what
okay.
about doubling up?
That's another option. Very good point. Yes. So we've also heard that if you don't have access to a KN95 or an N95, you can layer a surgical mask with a cloth mask, for example. So what you want to be sure you do is to make sure you get the best mask with the best fit that you can tolerate. That's kind of the language that the CDC is using. So doubling up is a good option. But make sure that there aren't any gaps. Make sure your mask covers your nose and your mouth. It's not going to do any good if it's only across your mouth. So that's another important point and a good option. You can double up as well. So Colleen.
Thank you.
Thank you. Where does the KN95 mask fit into that?
I think you could draw parallels to the N95. It would be along that lower right corner. I don't know absolutely if it perfectly, aligns with the N95. N95 is your utmost protection. KN95s, KN94s are pretty darn close. So that is also going to give you, greater length of protection when you're indoors, with our kids in school. If you're going to medical appointments, make sure you can skew towards that KN95 or N95 option, if at all possible.
Thank you.
Yes. Other questions on masks? Okay. And just as a reminder, if you raise your hand, if you want to lower it, just so we can kind of keep tabs if we've answered your question. So next up is testing. I know this is a source of confusion and frustration.
Amy?
Yes.
Quickly, two other questions that came through. Leslie wanted to know if the graph that you just showed was updated for the Omicron variant. And Sylvie wants to know, what about KF94 masks and double mask techniques?
Okay. So that chart has been shared widely in the face of Omicron, because what we know is that since it's so contagious, that's why we're encouraging everyone to wear the N95s or the KN95s, KN94s. What is abundantly clear at this point is that, clearly nothing is not an option. Cloth is not a very good option anymore. We kind of emphasized that early in the pandemic as a way of kind of saving the more, higher grade surgical mask and N95s for our healthcare workers. Now that we have the supply, we're encouraging everyone to take advantage of those because of the extraordinary contagiousness of this virus. So that is more appropriate. And I think that's the reason that we're, sharing that now. As far as the KN94s, my children's school, that's what they're also doing. The state of California is providing masks to schools to distribute either KN94 or KN95s. It's up to you. And I think you have to maybe assess your own family's, risk level. If your kids are going to be going to school and then coming home and potentially introducing virus, you may want to have them double up if they can tolerate, that. And I think there's good evidence that doubling up does provide even more protection. So what's clear is that you just need the best mask you can get your hands on. Okay. So now we're going to switch and talk about testing. So PCR versus rapid antigen tests, these at-home tests that everybody's talking about. Both of these tests can detect active infections. This is in contrast to our antibody tests, which detect a prior infection, previous exposure. So PCR stands for polymerase chain reaction. It's the gold standard for a test, and it detects the genetic material, the RNA of the virus. So the SARS-CoV-2 is an RNA virus. Some viruses have DNA genomes. This one has an RNA genome. So with PCR, they use special enzymes to convert that RNA to DNA, and then they make more copies of it to see if you actually have the virus. Rapid antigen tests detect protein of the virus and not the genetic material. And the nice thing with these is they have become widely available, or over the counter at least, where you can test for the presence of the virus from the comfort of your own home and get results in as little as 15 minutes. This is in contrast, as we all know and probably have experienced, with PCR tests where we're, best case, we were having maybe 24-hour turnaround. Now it's sometimes 48 hours or even days later. So we've all been grappling since Omicron surfaced with issues around test access, availability, and turnaround time. And that complicates an already complicated picture and a frustrating one, because you need timely results to know, one, are you infectious? Have you been exposed? And can take appropriate action. So some questions around when should you test? You know, ideally, everybody is doing surveillance testing. So even if they don't have symptoms, maybe they have decided that weekly, and I know many families with kids may do this to keep them in school, they want to do that rapid test to see if they're positive. Otherwise, we talk about symptomatic testing. So maybe you have symptoms, clearly you're going to want to get a test. If you have anything that looks like a cold symptom, sneezing, coughing, sore throat, fever, any of that, you need to get tested. Maybe you've been exposed to somebody who is positive and you need to get tested. So, you know, there are various situations, and part of it depends on your access to these different testing options. In my own case, I have two kids who were in school. One is in 4th grade, one is in 7th grade, and they had started back January 4th, that week after the holidays. So on that Saturday, after they had been in school for 4 days, I tested mine with a rapid test. This happened to be the Binax test. Neither of them had symptoms. And my son actually turned up positive. He had a weak positive test, and over the course of that day, developed symptoms. So he started developing stuffiness and sneezing. So he actually did have a mild case that week and progressed. I tested him again on Tuesday. It was a stronger positive result, and I confirmed it on both a Binax and an iHealth test, which is another brand. And by day 5, he tested negative. So I've kind of gone through this experience recently. I know there are questions about which test is best, PCR or rapid antigen. Again, PCR is kind of considered the gold standard, but we know that there are challenges many places around the country with turnaround time and not getting the results in a sufficient time to inform your actions. With rapid antigen tests, I often get the question, what brand of test? I have personal experience with both the Binax and the iHealth test. I've confirmed that they both work. What I can tell you is that the FDA does provide a list of the tests that have an emergency use authorization. So that includes Binax, it includes iHealth, it includes QuickView. There are a number of others that are on that list. So we can look up that link and make sure that you have access to it. So if you're looking online or maybe in a store and you see one, you want to know, like, is it legit? Is it FDA authorized? Then we can make sure you have that information. Of course, you probably all heard last week, the website is now up where you can get 4 free tests per household. The website's there, covidtest.gov. I encourage you to do it. It's super easy. I signed up for myself, and hopefully the technology holds and we all should be getting tests here in the coming weeks. So I encourage you to go do that as well. I'll go ahead and show you a graph, which I think can help explain some of the differences between PCR and rapid antigen and their sensitivity. And then we can pause for questions. But everybody wants to know, when will the COVID test show up positive? So here on the left side, the y-axis, you see viral load. That means how much virus you have in your body. Across the bottom x-axis, you see days since exposure to the virus. So we're starting at day 0 on the left and going forward in time. Now, once you're exposed to the virus, by about day 2 or day 3, your body is going to start making more virus, and you're going to start having a certain level, low level of virus in your system. Now, the red curve shows the amount of virus that's in your body. And we see the dark blue line is the amount of virus that's detectable by PCR versus the brighter blue line at the top, how much virus is detectable by those rapid tests. So you can see there's a little window where the PCR testing might be a little more sensitive early on post-infection. And then by about day 3, you start being able to pick up the virus by these rapid tests. Now, your body's going to hopefully clear the virus, and you see that viral loads start to drop off over time. And what you see, and this is part of the challenge of, isolation and those revised guidelines, is that PCR can continue to pick up virus for a longer period of time. Now, what we're detecting is the RNA of the virus, and that may not always equate with infectious virus. So you see there kind of in the darker pink in the middle, that's the infectious period. So that's where you can potentially infect others. But your PCR is still going to be able to detect, the RNA for longer. And that's why, as we talk about the CDC guidelines momentarily, there's been a lot of confusion about, if somebody tests positive longer than 5 days, what does that mean and how should they proceed? So there is a little bit of difference in the sensitivity of these viruses. Again, with my son, I did pick him up before he was fully symptomatic, and and then I saw him become more positive by day 3, and then he was negative by day 5. That varies in, case to case. I have other friends whose child remained positive by rapid test until day 10. Dr. Bob Wachter, who's a thought leader on this from UCSF, his 28-year-old son also remained positive for, beyond day 5. And it wasn't until day 10 that he tested negative. So hopefully this gives you a little bit of a better understanding of the sensitivities of these two different types of tests. The other thing that a lot of people have been hearing and talking about is, should I swab my throat? Because we know, or we've heard that Omicron tends to prefer your upper respiratory tract instead of deep in your lungs, which has been the original strain in Delta. So we now have data that shows that nasal swabs still outperform throat swabs. This was a study conducted by scientists out here at University of California, San Francisco. And this was among a group of patients who did have a confirmed case of Omicron. And what they found is that if they swabbed the nose only, there in the blue bar, they had about 86% sensitivity. This was with a Binax test. If they swabbed the throat only, they had about 47% sensitivity. And if they did both together, it bumped up just slightly to about 90%. So what's clear is that, and what the FDA actually recommends is that you only follow the directions of the test, which are to swab your nose, not your nose and your throat. You might get a little bit of a enhancement with your throat, but nose only should be sufficient, and is how these tests were designed. So that's kind of what I was going to say about testing. I'm going to pause there because I anticipate there may be some questions.
Amy, thank you so much for this information. These are great slides. Testing is really complex. The right test at the right time. And I think these slides are great visuals for us. Thank you for that. In the chat, I do see a couple of questions. There's questions about antibodies. There's questions about travel. And there is one, the most recent question that was posed is about the timeline. And an oncologist shared that someone might test positive for up to 20 days.
Okay. So I know there's always a lot of questions. The antibody one, I think, can you remind me what that specific question was about, Christy?
Oncologist told me I might test positive for 20 days after COVID infection. Trying to get to Maui in March. I need a negative PCR test to fly back to Canada. Can I really test positive for 20 days?
So that gets back to this curve that I just showed you. So with PCR, it's not uncommon for people to continue to test positive for extended periods of time. The good news is that that is typically beyond a period at which you're actually infectious. Now, that gets complicated because of different travel guidelines and what results different people are willing to accept, because, it's kind of become entrenched in us that PCR is the gold standard. I can tell you that our own colleague, Dr. Upal Basir-Roy, just traveled to India, and Binax actually has a proctored version of its test that is sufficient for international travel. So I encourage you, if you're thinking about, travel, other scenarios where you might be able to do that. So one, yes, you may still test positive for longer, periods. That doesn't necessarily mean you're infectious. So, talk with your doctors, talk with, your airlines and other travel places to figure out, what tests they're willing to accept. With antibody tests, that's something completely different where, again, that's confirming if you've previously been infected. People also want to know about their levels and are they protected from their vaccinations and from their boosters. What I can tell you there is that kind of the tests that we normally go in for, like at Quest and these commercial tests, aren't necessarily yet validated for that purpose. Now, when I say that, there's been a lot of intensive research over, the course of the pandemic, and certainly since vaccines came out, to determine what we call the correlate of protection. What level of antibodies do you need to be protected? We're just beginning to understand that, and what level is sufficient in people, and how that correlates with different groups who have different pre-existing conditions like cancer. I'm part of a study through Mount Sinai that's studying kind of the antibody response in patients with lung cancer specifically. So we're learning a lot. I would say, don't go, the CDC advises against going out and just getting your antibody levels assessed, because we don't fully know yet what level or titer is necessary and sufficient. So hopefully that answers part of the antibody question. And then did you say there was one more, Christy?
There is. Let me scroll back up here.
I think there was one about, maybe it was Elisa who was asking about her son who had 2 vaccines, had a breakthrough case, got boosted, and wanted to know about antibodies. Was that right? I think that's
correct.
Okay. So in that case, I think what we know is that there's data that's been coming out over the past couple of weeks, just looking at the role of previous infection compared to vaccination. And what we now understand is that those who were infected with Delta may have, an added, we've talked about super immunity. They may have an even greater level of immunity than those who only were vaccinated and never had natural infection. I would think in his case, I would expect that, he probably has a pretty robust antibody response in the face of all that, but we're not yet at a point where we're recommending that the general public kind of go out and get their antibody levels measured. So hopefully that helps answer part of that question.
So our question was, can he still be an asymptomatic carrier?
Oh, right. So I don't know the timing exactly of his situation, but it sounds like some time has elapsed from his case, because he waited 2 weeks to get boosted, and now we're presumably at least 2 weeks or more beyond that. He should not be an asymptomatic carrier at this point. And like I said, even if he were to show up for some strange reason positive on PCR, that's probably just remnants of the genetic material, but doesn't necessarily correlate with infectious virus. So he should be in the clear by that point.
Thank you for addressing that, Amy. There are a few more questions around antibodies, and I had a vaxxed and boosted, how long, and had a breakthrough case. How long am I protected? Does this affect my lung cancer? And
was the breakthrough with Omicron or Delta? Do we know?
It doesn't specify. It was in January, just recently, early January, I believe.
It was likely Omicron then, because we were already at Omicron being 90% of kind of cases by January. So we don't know yet how long or how durable the immune response to Omicron will be, because the reality is it only was first detected around Thanksgiving in South Africa. So let's say even those people who were initially infected, they're not quite 2 months out from that. So we don't yet know how long term, best data we would have would be 2 months worth. So we don't know if it's going to last 3 months. We don't know if it's going to last 6 months. We don't yet know if you're going to be recommended to get a booster following a breakthrough infection with Omicron.
Marty has her hand raised.
I see that.
That was my question. And I had sotrovimab. So I had monoclonal antibodies.
Uh-huh.
And I didn't know, does that afford me greater protection for a longer period of time?
What we had said historically before Omicron and before those monoclonals is if you had received monoclonals, you kind of maybe have a period of, 3 months or so where we would maybe think you're okay before potentially thinking about a booster. So I say you do probably have some protection, but we don't yet know the full durability in the face of Omicron. We do know that people can be reinfected even with Omicron, given its contagiousness. So, I've had this question before, even from like our good friend Jill Feldman, who had a breakthrough case over the holidays, wondering, should she, and I'll address this later, but should she get a fourth booster now? Should she wait? And so, I'll be addressing this, but we're anticipating Omicron specific boosters maybe as soon as March. So I would think, data that we've seen in our own study of patients with lung cancer shows that the majority of them do mount a robust antibody response to vaccination. There are a few outliers who do not, or who initially do and then it falls off. But by and large, as a whole, the population seems to be fairly well served by vaccination and by boosting. And I think you're probably going to have some additional protection from that breakthrough infection. Still, I'm a PhD, not an MD, so I advise you to talk to your treatment team, to your doctors, and have a conversation about what's appropriate for you in your particular situation. But you probably did have a nice little bump in your antibodies.
So the sotrovimab won't affect my lung cancer then?
No, it should not, adversely affect your lung cancer. But again, if that's something that you're concerned about, talk to your treatment team. That's a recommendation. Again, telling the anecdotal story of Jill Feldman and her experiences, she had a breakthrough, got monoclonal antibodies herself. And so I think that's a standard kind of, course of action for people who do get breakthroughs. Okay, I'm going to keep moving because we have a good bit of ground to cover. You're welcome. So revised CDC guidelines, this ties into the testing piece. So there was a lot of confusion when these first came out, a lot of frustration by those in the medical community and public health because of how it was kind of communicated. So what we know now is they say, if you test positive, looking at the left side of this figure for test positive for COVID-19, you were advised to stay home the first 5 days. And they said, if your symptoms seem to be resolving, that you were okay to leave the house as long as you wore a mask when you were around others for the next 5 days. We have since seen these guidelines updated to say, if you can get access to a rapid test, that you're encouraged to go ahead and administer that test at day 5. I think that was recognition that, again, some people are going to stay positive for longer than 5 days, but, kind of a concession by the CDC that not everybody can get their hands on a test right now. So ideally, you want to test, again, with a rapid test at day 5. If it remains positive, you probably want to stay in for the full 10 days. If it's negative by day 5, you can kind of emerge from isolation, continue to wear that mask. And they said rapid tests, because of these issues with the PCR test continuing to show positive for longer periods of time, although you may not be infectious. If you were exposed to COVID-19 and you have been boosted, this is in the middle, you're going to want to monitor yourself over those 10 days, make sure you don't develop symptoms. You want to test on day 5 in the middle of that if possible, because if you've been exposed, you're probably going to turn up positive or start having symptoms maybe as soon as day 3, but certainly by day 5. So do that test at day 5. And then, if you do test positive, you kind of go to the left side of this graph, but if you remain negative, just keep wearing your mask until day 10. If you were exposed to COVID-19 and you were either unvaccinated or were vaccinated more than 6 months ago with either the mRNA vaccines or more than 2 months ago if you got J&J, stay home days 1 through 5, get that test at day 5, and then continue to wear your mask around others. If you're improving or if you remain positive, then stay in for the full duration of the 10 days. So everybody wants to know, when is this nightmare going to end? Is it ever going to end? So what I can tell you is that as of January 21st, last week, when I looked at the data, certain places in the country had already peaked or plateaued. So when you look at some of the places that were initially hit first, like New York City, DC, Boston, kind of the Northeast, they're already starting to come down. Another way that people track the presence of the virus is in wastewater. So in Boston, they've seen the amount of virus in the wastewater coming down. New York City has hit its peak. But these peaks are going to occur at different times across the country, according to, different local, challenges and just when, the big populated areas are probably going to peak sooner than the more isolated parts of the country. And we see that the Midwest and the upper Midwest is still increasing. The good news is that the worst should be over by late February, early March. And so if we look at, this is from the New York Times, I pulled this yesterday, the national picture is on the left. So you can see that red line is the number of cases. It has peaked and is starting to come down when you look at the nation as a whole. But again, that's with the caveat that certain places in the country are continuing to go up. Now, the figure on the right just shows what we look like nationally. And it's clear that we are still awash in COVID-19. It's still very high everywhere you go. So, when you look at these curves, kind of that bump in the middle on the left, that red curve where it says 7-day average, that was last winter's surge. Then you see this little kind of hump before the big spike. And that was our Delta surge this summer when we thought, oh, this was pretty bad. Look how high we are. So even once we peak, it's important to remember that we have to come down from that peak. And that still means there's going to be lots and lots of cases until we kind of get back to some kind of baseline. So please, please, please don't, take peaking as we're done. We can take the mask off. We can relax. We've still got a lot of virus out there and we still need to take precautions because it's still going to be a bumpy ride for some time to come. So what's the impact of the vaccinations on this latest surge? So here on the left in red, you see average daily cases. What we see is that the top line shows that unvaccinated cases are twice as high as they are among those who are fully vaccinated in the pink line. So of course, you still get breakthrough infections with vaccination and with boosting. These vaccines were never intended to block infection or transmission. We got lucky initially in that they did seem to do some of that and continue to do some of that, but we're still going to get cases even if we're vaccinated. But what that translates to in terms of deaths on the right is that deaths are 20 times as high in those who are unvaccinated compared to those who are fully vaccinated. Vaccination is your best safeguard against severe outcomes, including death. So we strongly encourage everyone with cancer, especially, and those around them to get vaccinated because that's your best way to stay safe. So that brings us back to our community. What is the risk for patients with lung cancer specifically? So, this has been an area of passion for me because I am a trained virologist, yet I work in lung cancer advocacy. And when the pandemic started, I realized that my worlds had converged in a way that I never anticipated, but I quickly realized I had to do something to try to educate and empower our community. What the early data has shown, going back to 2020, is that there's high mortality in patients with lung cancer, as high as maybe 35%. That's been shown by multiple different studies now. Luckily, the data has shown that vaccines are safe and effective for patients with cancer. And in various studies, it's been shown that the majority of patients with solid tumors mount a strong response to vaccination. As I alluded to, there are some outliers. Again, I'm part of this large NCI-funded study being led by Dr. Fred Hirsch and Adolfo Garcia Sastre at Mount Sinai, where we are working to understand the antibody response in patients with lung cancer, how durable it is, the magnitude of it. And what we've seen in our own study of now about 180 patients is there are a few outliers, patients where maybe their response is not as strong, and we're trying to understand the reasons for that and if that gives us guidance for more tailored vaccination regimens for our community. So clearly the risk of breakthrough infection remains even if you've been boosted, and these breakthrough infections can be serious. So just a few quick anecdotes along those lines is hopefully, I'm sure many of you have seen the article that Ivy Elkins wrote, kind of summarizing Jill Feldman's experience. Jill's one of the co-founders of the EGFR resistors, had a breakthrough infection over the holidays. And her experience, was pretty scary for her. She ended up in the hospital her oxygen was dropping. She did get monoclonal antibodies, but it took her some time once she got home to kind of recover from that experience. And fortunately, she did come through it, but there have been growing stories of patients with lung cancer, unfortunately, who have passed away from breakthrough infection. We have a case that we're hoping to develop a case study around out of Mount Sinai of a patient who passed away. I have family friends here whose father in Colombia, South America, was just diagnosed with COVID and is being put on a ventilator as of yesterday. So it can still be pretty severe for patients with cancer. And, my primary motivation in all of this is to keep all of you safe and to share whatever knowledge I have to achieve that. And so this is some data from a recent publication in the Annals of Oncology, looking at patients who had been fully vaccinated but had a breakthrough infection of COVID-19. And you can see that among those patients who were fully vaccinated, 65% did require hospitalization, 19% required ICU admission or ventilation, and 13% died within 30 days. So I think hope is important, but I also think it's important to be realistic and mindful of the data so that you can make informed decisions about what things are important to you as you make choices about how to navigate your daily lives. So just know that the risk remains. I don't want people to feel, a doomsday approach to the pandemic, but I want them to be prepared and to have that data. So it can still be quite severe. So I'm going to pause there. See if we have questions from that chunk of information.
Thank you, Amy. More good information. There are quite a few questions here. Of course, there are questions on air travel and flying that we can get to. There's a question specifically, I think it's from Lou. Let me go back to it, about available data on T and B cell immunity. What part of the population may have this immunity? Another comment is curious what you're hearing about the Evusheld, the prophylactic monoclonal antibody.
Okay. T and B cells, the good news is that with Omicron, early indications are that we may have a broader immune coverage. Our immune system seems to be adapting. So when we think about the immune response, there are kind of two lineages of cells. The B cells, those are the ones that make the antibodies, and there are T cells, and they can actually hunt down and kill the virus. And they play a role in stimulating those B cells to make antibodies. So they kind of work in tandem, kind of like Batman and Robin to fight the nasty virus. And so, everybody's been fixated on, oh my gosh, do I have enough antibodies? What's, my antibody level? And we always say, don't forget the T cells, you probably have a T cell response, and that's good. The important thing to know is that B cells and T cells are smart. They can remember things that they've seen in the past. Even going back to like people who lived through the 1918 pandemic. When I was at Vanderbilt as a postdoc, there was an investigator there whose work was really to assess antibodies like that. And he went back to samples from the freezer from people who had survived, derived those antibodies, and was engineering them in the lab as a potential, protection against pandemic flu outbreaks. So it's really cool what the immune system is capable of. And I think, we're working to understand fully what the T cell response looks like. And even with the study that I'm part of, we're collecting now additional blood from patients on our study who have been vaccinated and boosted so that we can do some of those assessments to look at the T cell response. So this is an area of intense investigation by multiple labs around the world to really understand the full breadth of the immune response and how it varies with Omicron compared to earlier waves. So much more information to come in the future. We'll probably save the travel ones for the end.
Perfect.
And then what was
a couple more questions have come in about the darn steroids. Should they be avoided completely, if possible, while community spread is high? Another question about, are all lung cancer patients at the highest risk, or is it more risky for those currently in treatment versus someone who may be stable or NED?
Okay, I realized I forgot the Evusheld question, so that's one. Let me back it up to Evusheld. So yes, that's a new combination that has come out that's supposed to be a prophylactic for vulnerable people. Actually, I was on a call with Dr. Paul Bunn, who's one of the leading lung cancer experts last week, and he was asking this question for a family member himself. And what we know is that of that combination, one of the drugs doesn't work quite as well against Omicron. So although it may work, it's not as good compared to sotrovimab, for example. So more to come for what role Evusheld may play. The challenge with Evusheld and some of these other oral drugs that we've heard about with Merck's new molnupiravir drug, as well as Paxlovid by Pfizer, is that they're hard to come by. So the country's been kind of clamped down on distribution of those to different facilities. I think I saw that when New York was at its height of Omicron, that, for however million people there, it had like 1,600 doses of Pfizer's drug available. So, that's been the other thing that we're grappling with, not only limited tests, we're having limitations on availability of monoclonal antibodies and some of these newer antiviral medicines that are out there. So that was that one. With dexamethasone, steroids, we know that those who are on kind of steroids for different conditions kind of long term, that probably is going to dampen your immune response. We're working to understand that. I think that's a conversation to have with your doctor and your team to understand if there's anything that can be done to increase your response. I think we have seen examples on our study of patients who maybe didn't respond to the first 2 doses, and then for whatever reason, by 3rd dose, they did suddenly develop an immune response. So there's a lot of variability out there, and it probably depends on multiple aspects of an individual's overall health profile and what else they may have going on in addition to the lung cancer. I think with, as I said, with the study that we're doing to understand the nature of the immune response in patients with lung cancer, we're very focused on those individuals who either have failed to mount a response, or those individuals who maybe initially did and then it fell off over time. Are there any commonalities? I think if you look at cancer as a whole, there are certain things like active treatment, chemotherapy, chemo-IO combination that may mean you don't respond quite as well. For most purposes, those on targeted therapies tend to look more like general public, but that doesn't mean that they can't have a serious breakthrough. Again, I point back to Jill's experience, who's on a targeted therapy. So it's a complicated landscape. I want to reassure this community that there's a lot of work underway. We're learning more every day, and that, we're in a much better place overall than we were when all this started 2 years ago. So let me pause there, see if we have more questions.
My goodness, this is great information. We definitely are more knowledgeable than we were 2 years ago, most definitely. Another comment was about monoclonal antibodies being difficult to come by, to locate, to get. What other options are there for early stage disease?
So, we tend to think about kind of 3 classes of drugs if you're non-hospitalized, and then there's some other options if you are hospitalized. So, we do think about those monoclonals. So again, the sotrovimab, because we know that's the one that seems to work best against Omicron. So it's kind of in precious, limited supply right now. It's hard to come by. It's very precious. Hopefully manufacturing and production of that will ramp up so that we have more of that in our stockpile. That's not to say going forward that we won't have, Omicron is different because it kind of, when you look at the origins of this virus, you kind of had certain lineages that include the original strain and Delta and Beta and whatnot down here. Then Omicron was like its own little offshoot. So it's different than the other strains. And because that has different reactivity to some of these monoclonals, now going forward, we may be able to pull some of the other monoclonals back into our, back into use. That remains to be seen on how the virus unfolds over time. Other options are those 2 oral drugs. I talked about Merck's pill as well as Pfizer's combination pill. The one caveat about Merck's, and again, this is, there's still supply issues, but Merck's is not recommended for women who are pregnant because it may cause issues there. With Pfizer's, it reacts with everything. So it interacts with so many drugs. So, you need to talk to your doctor and make sure they know every single drug you're on, because it can adversely interact with lots of things. So just that's another thing to keep in mind. So unfortunately, we're just in a situation where we need to ramp up production of some of these drugs. If you're hospitalized, the options are to get remdesivir, to get dexamethasone, so you may get steroids, depending, because a lot of patients experience blood clots with a COVID case. They may put you on high-dose IV heparin to help with some of the clotting issues. There are some drugs that are being repurposed. So some like arthritis drugs that can help dampen the inflammation. So as I said, we're learning more, we're getting smarter about how to treat COVID. So we've made a lot of progress. Our biggest challenge here is not necessarily the severity overall of Omicron. It's, just the extent to which it's infected so many people that, we're now more short-staffed for healthcare workers than seeing some of the severity of disease. But again, that's, in this population, it still remains a severe risk. So let me get through the rest of this and then we'll pause again. So boosters, I just wanted to share a few comments about that. Let's see if I can, okay, there. So how did the boosters perform against Omicron? Here we're looking at the effectiveness of 2 or 3 doses of the mRNA vaccines against Delta and Omicron. On the y-axis, you see vaccine effectiveness in percentiles. The blue line is Delta, the red line is Omicron. If you look at the numbers on the left, that's in people who got their vaccines less than 6 months ago for their second dose. In the middle, they got it longer than 6 months ago, that second dose. And on the right, this is following a third dose. So what you can see, this is protection against visits to the ER and urgent care. So the Omicron, the vaccines, did show some, they weren't as effective. They are evading that immunity. And so what we see is that after a third dose, you get a nice restoration of protection against ER and urgent care visits. So boosters are very, very important in the face of this Omicron surge. Now, how does that compare with hospitalizations? Here, same curve, we're just looking at effectiveness against hospitalization. Again, what we see is that if you got the vaccine dose 2 relatively recently, 6 months, less than 6 months ago, maybe it's 81% effective, you get a nice little bump up to 90% after a third dose. If you got your vaccines more than 6 months ago for mRNA, more than 2 months ago for J&J, you really need to get that booster to keep you out of the hospital. So that's what we know so far there. And then, as I said, these vaccines were never expected or intended to prevent infection. They were designed to keep people from dying. They've performed beautifully in that regard. The icing on the cake is that they do seem to afford some protection against infection. And even during this Omicron surge, being up to date on your vaccines does provide some level of protection against infection. So what the CDC reported last week in a study is that adults who were unvaccinated had a 5 times higher risk of infection compared to those who had been fully vaccinated with a booster. So you're still getting some protection against infection. But again, the main point is that you're being protected against severe disease and death. Everybody wants to know, should I get a 4th shot? So CDC is now allowing for a 4th dose in immunocompromised individuals who are at least 5 months out from their 3rd dose. And what I can tell you is there are certain groups, those with blood cancers, transplant recipients, where this makes absolute sense and, is the way to go. But data emerging out of Israel, and they've really been at the forefront of a lot of the studies on boosters. They were some of the first ones to give boosters to general population and whatnot. Their data is showing that maybe you get some enhancement of your antibody levels, but it's still not going to be enough to prevent breakthrough infection. So what I think I need to stress here is we are not going to boost our way out of this pandemic. That's not the end game for COVID-19. It's important for protecting you against severe infection and death, but it's not going to be what brings this to an end. So in terms of the fourth dose, timing is important. Talk to your healthcare team because Omicron specific boosters are coming soon. You know, we've heard that it could be as early as March. So if you have had a breakthrough infection, you know, since the holidays, you probably are going to have, you know, a window where you have protection from that. So do you go ahead and get the fourth dose against the original virus, or do you hold out and wait for something that's more specific to this latest variant? More to come there. We're learning our way through this. We're only a couple months out, as I said, from Omicron's first appearance. So we're still learning as we go. I'll pause there. How are we doing on time? Okay, we got a few minutes left.
We're doing okay. We've got a few minutes. One of the things I didn't hear mentioned is about our children, and
Yep.
specifically those under the age of 5.
Yes, that's a big concern. You know, I'm a mom, I get it. We have so many, you know, of our neighbors in our little subdivision who all have littles, and, you know, it's scary. It's frustrating because they feel like they can't really move on yet. And they see the world around them. It feels like everybody's moved on but them. You know, I wish I could just tell you the booster or vaccines for under 5 set are going to be available next month. I don't know. Honestly, you know, Dr. Fauci has said it may be a few more months. If I'm going to be fully transparent, I can tell you that Pfizer's data is not looking good for its mRNA vaccines in the under 5 set. And truthfully, we don't really know the reasons for this. I don't know what that means for Moderna's vaccine. There are other vaccines that are in the pipeline, other modalities. So we think about mRNA vaccines with Moderna and Pfizer. We think about adenovirus vectored vaccines with J&J and AstraZeneca, for example. There's one that's being developed by a company called Novavax that is a protein subunit vaccine. There is a precedent for that type of vaccine with other things. So that may be an option that becomes more viable for younger children. We just are at a place where we're not there yet. And the science is moving as fast as it can. And we've all got our fingers and toes crossed that it will be here soon. So I wish I had better news because I know so many people are waiting and so many of you have young kids or grandchildren and you just want to be able to be with them safely. So, you know, we hope that something will become available to them soon.
Absolutely. Absolutely. Amy, you did a great job of addressing actually some of the questions about boosters and the timeline. So thank you for doing that. There are a couple of additional questions. We have a few more moments. An expired rapid test, should it be disposed of immediately?
So, you know, the FDA has granted extended emergency use authorization. I don't know the brand, but for Binax specifically, as I mentioned, there are some that are proctored for international travel, and I think they've extended the expiration dates initially to 1 year and then to 15 months. So you may be able to search your particular brand and lot and expiration dates and see if they've been adjusted at all. You know, some of the Binax initially was like 6 months and then it was 9 months, and they keep kind of stretching it out. And I don't know if that's because they're confident in the materials of those, you know, original lots, or if they've changed their manufacturing, you know, protocol at all. But I do know that those are slowly being extended. So I encourage you to go online and see if you can find out any information.
Definitely follow up with the manufacturer. That's great guidance.
The other important thing just on that is, you know, as these tests get shipped by the government, you know, they do have to be maintained at certain temperatures. So you don't want to keep them at freezing. I know a lot of people are concerned about when those get shipped and if they would be delivered to your house and maybe left outside and it's, you know, the middle of winter. So you do want to store them, at, kind of in your house at reasonable temperatures. They don't have to be refrigerated, but, do take care in how you store them and follow those recommendations. Specifically, you may not want them out in a cold garage, for example, because it may compromise, the integrity of the test. So just follow the directions.
Another great point for consideration, the storage. Thank you, Amy. We're still learning, but any information on long-term late effects of Omicron?
It's too early to say. I do know that we
That's
expect
fair.
that long COVID could be an issue with this one as well. It's, even though it seems to prefer your upper airways compared to, your lower lung, the receptor for the virus is found, all throughout the body. So that's why we see such varied impacts of COVID infection. So TBD, I'm obviously having a son that just went through it. I'm as concerned as everybody else and anxious to learn more about what infection with Omicron may mean long-term. But the good news is if you've been vaccinated, if you've been boosted, you tend to clear the virus more quickly. There does seem to be a reduction in risk of long COVID. So again, there are multiple benefits to getting vaccinated and boosted. I see Leslie has her hand raised.
Absolutely. Two more questions, Amy, we want to make sure that we address before we wrap our time up. And Leslie, we'll get to your question also. What's the next variant coming around the corner? There have been multiple questions about that.
Well, I saw on Twitter yesterday, there's several thought leaders that I follow, and there's an offshoot of Omicron in the Netherlands, and time will tell if it continues to kind of bubble up and spread, or if it, kind of just goes away. People don't realize that we've had, alpha, beta, delta, gamma, Omicron. There have been all the letters were up to Omicron in the Greek alphabet. There have been some variants that have emerged and haven't taken off. They didn't outcompete Delta. They didn't outcompete Omicron. I think going forward, probably in thinking about vaccines and vaccination approaches, similar to what we do with flu, we talk about, the quadrivalent flu vaccine. You have, protection against the flu A, a flu B, the H1N1. So you've got multiple types of flu viruses that make up that vaccine. That may be the direction we're headed in the future, is kind of layering in multiple different variants to give us protection. And I'll talk about that kind of in this future, forecasting here in just a moment, but go ahead with your other question. Okay, I don't know if we lost Christy. Leslie, did you have a question?
Yeah, I just wondered, I got my booster back at the end of September. So I'm going on 4 months now.
Okay.
And everything that I've read says that, well, your protection, it drops precipitously after about 3 months. So I'm wondering, and I've never been able to find this out anywhere. I know that my protection against Omicron has waned a bit. How protected am I against Delta? And is there any sort of data as far as how long this booster tends to protect us?
As I said, that's an area of intense investigation. There's the whole NCI funded SeroNet program that's 25 institutions across the US that are working to ask that very question, how long does protection last and against what strains? What does the B cell response look like? What does the T cell response look like? So I don't have a clear answer to give you today. I know that it's something that we're all anxiously working toward to understand. So more data comes out every single day. So we're learning more. It doesn't give you a clear direction, but I'm sorry. But talk to your doctors, look at your overall health profile, other pre-existing conditions and age and make a determination based on that.
Thank you.
All right.
Thank you,
I know we got to
Amy.
wrap up, so I'm just everybody wants to know what's coming. So will this ever end? Things to look forward to: Omicron specific boosters, Pfizer, Moderna, everybody that's got a vaccine is working on Omicron specific boosters. They may come online as early as March. So, definitely by spring, we're thinking about other vaccine options. And Leslie, this gets back to you, that might be a better alternative for you by then. as long as there are people to infect, this virus is going to change and variants are going to emerge. And this brings back issues of global vaccine access and health equity. You know, it's not enough to be where we are in a place of privilege and have access to all the boosters and whatnot that we have when some people in the world haven't even gotten their first dose. But there is an investigator in Texas, Dr. Peter Hotez, who is has worked on tropical diseases and other infectious diseases historically, and he just developed a vaccine, a protein subunit that he's making. It's approved in India. He's making it available globally. Can be easily manufactured, low cost, easy to administer, and he's hopeful that that will help with some of this global access issues. And again, if we can get more people vaccinated, that helps us keep other variants at bay. And then, okay, so there's just, an endless, endless variants, it seems. So the US Army is trying to work on a pan coronavirus vaccine. This is kind of one that would cover all our bases and work against any variant that may come in the future. So there are efforts to develop pan coronavirus vaccines. As I said, none of the vaccines that we currently have available were designed to block infection or transmission. Full transparency, my husband's also a virologist. He has a company. He's working on intranasal vaccines that hopefully could help block infection and transmission. So, there are going to be next generation vaccines. I don't know if his is going to work. There are other groups that are pursuing this approach. That is an end game solution to this pandemic is, can we stop the infection? Can we stop transmission? Yes, we want to stop people from dying, but we won't stop getting it in the first place. And by going through the nose, you're stimulating other antibodies, IgA, mucosal immunity that can hopefully attack the virus when it first enters before it gets into, a systemic infection. What does endemic mean or look like? So we all keep hearing this virus is going to become endemic, which means it's going to be with us kind of forever. So that means it's not just that everybody's sick with it all at once. This is an emergency situation we're in. This is pandemic, an epidemic within a pandemic. Endemic means it's at a low enough level that you're going to have occasional flares like you do with the flu, but it doesn't overwhelm the healthcare system. Everybody, it doesn't crumple your infrastructure, supply chain doesn't shut down. That's the risk that we're facing right now. Even so, modelers, including Dr. Trevor Bedford, there's a Trevor Bavona who's a lung cancer expert, Trevor Bedford in Washington, just won the MacArthur Genius Grant. So he's done a lot of excellent modeling of the pandemic. He predicts we could still see 100,000 deaths per year in the US once we're endemic. When will we get to being endemic? Some models, including Pfizer, have said 2024. Others, like Dr. Bedford, have said probably next winter, 2022, 2023. So we're not there yet. As much as bad as this is, as many people are infected, we still have a ways to go to hit endemic status. So I've told you a lot of things. None of them sound terribly good or promising. So how do you find your own in the OMG? I always say knowledge is power. We're in a much better place. It doesn't feel like it, but we are in a better place than when we started this 2 years ago. We have very effective vaccines. We know more about how to treat COVID-19 than we did initially. We have effective non-pharmaceutical interventions. We have the tools, guys. We just need to use them. So masking, social distancing, hand washing, improved ventilation, shared airspace is important. So make sure you're, using it that way. Signs are pointing toward the virus eventually becoming endemic, not pandemics. That means it's manageable. And, basically what I want to achieve is to help you all make smart choices based on your individual risk profile and tolerance. What things matter to you, hugging your grandchildren or being able to travel, going to different events. How can you do that safely? How much of a risk does that present to you? And so just trying to be honest and transparent about what we know, what we still don't know, and to help you along that path. So I'm going to stop there. I'm sure there are more questions, but hopefully this was useful for everybody.
We're over our time today. The latest comments in the chat are kudos for you for the timely, informative information that you've shared with us today, Amy. It's an excellent presentation, and I think by and large, everyone's really appreciated the information shared. We'd also like to thank each of our participants for joining us today. Any other questions? As you know, we've got Dr. Amy who's keeping her finger on the pulse of all things COVID. We want to ensure everyone's safety. Take any specific questions you may have back to your provider for discussion, and stay tuned on further COVID updates to come as needed.
Yep,
Amy,
more to
thank you
come.
so much for being with us today. And this audio recording will be available on our LUNGevity site. Stay tuned for those details, everybody.
Thanks, everybody. Stay safe.
You too. Bye-bye. Thanks again.